Before we start, here's a question for you. Improving the health of migrants can only be achieved if you have 4 different options. You can scan the QR code on screen to respond. We will reveal the answers at the end of the session. And don't forget that this panel is going to be either in French or English, so for those who need translation, we have casks at the back of the room that you can grab so that you fully understand the session, because we're going to have panelists speaking either in French or English. And now it's my pleasure to welcome our moderator for the session, Michaela Told, Senior Policy Advisor at the International Organization for Migration. Mrs. Told has over 20 years of expertise in governance, policy, and diplomacy, specializing in migration, development, and global health. Michaela Told, you have the floor.
Thank you very much, and it's a great pleasure to be here with you today and to chair this panel. So I will not further go into any introduction. I think the topic is clear. Lessons learned, effective practices in enhancing migration health. And I have a great panel here, so I would please invite all my panelists to come up on stage. And so here's the plan. That's what we want to do here. I'd like to have a conversation with my panelists. And I'd like to ask you different questions about what you do and about practices from your realities. And I want then to open up also the floor for questions with all of you and an interaction, in fact. So it's a conversation. Let's have a conversation today. So let me start with Annalie Cockley from the University of Calgary. Thank you very much for the long way here to come here from Canada and to be with us here. You are the medical director of the Mosaic Refugee Health Clinic, but you also, of course, you are an advocate for patients' health. And you work especially with marginalized communities and migrants. So you have a number of different awards, and I won't introduce all the long CV you have and experiences, but let me ask you just right away the question I'd have for you. You're coming from Canada. Canada has a model of inclusion of refugees and asylum seekers in their healthcare systems. So can you explain us briefly how that looks like, how that works, please?
Yes, of course. Thank you. And first, thank you very much to the organizers of the conference. I'm very happy to be here. As you mentioned, you know, we've traveled a long way. I traveled a long way to be here, but I always feel at home when I'm with my colleagues who share my passion for migrant health. So thank you to all of you for being here. I was asked to speak about the Canadian model for refugee healthcare, and I'd first like to acknowledge the fact that Canada is very privileged in the world. We're a high-income country, and we're a very difficult-to-reach country. We're protected on 3 sides by massive oceans, and then on the other side by the American border. So I do speak from a position of privilege that I would like to acknowledge. And so first, to understand the Canadian health system, or the model for refugee health in Canada, you have to understand a little bit about the Canadian sort of structure, constitutional organization. And so Canada is 13 provinces and territories, and healthcare is provided by the provinces and territories. And so essentially Canada consists of 13 independent health systems. But those systems are regulated by the Canada Health Act, which sets forth principles by which every provincial health system has to comply. And the most important principle would be that of universality. So that means that every permanent resident of Canada in each of the provinces has to be provided access to our publicly funded health system. And so that would include refugees. So in terms of refugees, refugees come as either convention refugees or asylum seekers to Canada. And so convention refugees are being resettled to Canada as permanent residents. And so because they're permanent residents, they have access to the provincial health insurance plan. So they have access to mainstream health services in each of the provinces and territories. In addition, refugees also get supplemental health coverage by the federal government for their first year in Canada. And so this supplemental coverage is called Interim Federal Health Program, and this provides additional coverage for essential medications, for optometry services, and basic dental services. And so this they have in place for their first year, and after the year, they're considered resettled. So they become like any other permanent resident of Canada at that point, and then they're transitioned to the provincial system. And then their benefits under the provincial system would depend on their income. So if they're low income, like all Canadians, you have access to additional supplementary health benefits. With asylum seekers, it's a little bit different. And so asylum seekers are temporary residents of Canada. And so they're not eligible for the provincial health insurance. And so because migration is a federal responsibility, the federal government provides them health insurance so that they can access mainstream health services wherever they are settled in Canada. And so through the Interim Federal Health Program, they have coverage for health services, and they also have that supplementary health benefit package. So that would include the essential medications, optometry services, as well as dental, very basic dental services. And they have that until their claim is either accepted, in which case they become permanent residents and therefore eligible for the provincial health insurance plan, or they're rejected and deported, in which case they're deported and no longer eligible for health coverage. So this all might sound very wonderful in theory, but access on paper, as we all know, does not equal access in practice. And so as we all know very well, refugees face a number of barriers when attempting to access health services. So, language, navigation, transportation, cultural barriers, racism, et cetera. And so over the past 25 years, it's been noted that refugees have difficulty accessing health services. And so organically across the country, in every refugee receiving jurisdiction, independent refugee health clinics, which are part of the mainstream system, but they're specialized clinics that meet the needs, they're designed to meet the needs of newly arrived refugees. And so over the past 5 years, my research partner and I have mapped out this system, and we've collated the data we've gathered into something we call the Canadian Refugee Healthcare Atlas, easily found online. And what did we learn from our research? We learned that in Canada, there's over 80 refugee health clinics. And these clinics, they differ in terms of their structure, their funding models, but their healthcare delivery service is the same across the country. And so these clinics were designed to help people overcome those initial barriers. So they're partnered with resettlement agencies across the country. They provide interdisciplinary, comprehensive, trauma-informed primary care to refugees for a temporary period of time, so between 1 or 2 years. And once people learn to navigate the system, once they've had their acute issues, chronic diseases addressed, they're then transitioned to their permanent medical home within the mainstream system. And so, in terms of each clinic also has embedded specialists in order to avoid the navigation barriers. They also have access to interpretation. They also have public health embedded within the clinics. And so patients will be provided their catch-up vaccines right on site. And so in this way, Canada has organically grown this refugee health network across the country to meet the needs of newly arrived refugees.
Yeah, thank you so much, Annalie, for this first response and explaining us a little bit how your system works. I think it's very interesting. In the previous panel, we have heard how migration is political, and you did actually start with the political context. So it is within a political context that this all happens, but also you pointed out the whole gap between theory and practice. And so let me move from Canada and cross the ocean to France. Let me cross the ocean to Professor Nicolas Vignier. Happy to have you here with us. You're Professor of Infectious Diseases. You are Doctor in Public Health. You're doing action research with migrants in France. So let me ask at the Hôpital Avicenne and Université Sorbonne Paris-Nord. So let me ask you then my question to you. France also claims universal health coverage or healthcare system, but does it really work for migrants? Universal? And if, why not? Or if yes, if no? Over to you, please.
Thank you. So, because we are in Geneva, that is a French-speaking city, I have the opportunity to speak in French, so my presentation will be in French, and the one of my colleagues as well. So, please feel free to stand up and go back to take your translator if you don't, because it's not only for French to English, it's also for English to French. Thank you. Donc, je vais faire en français.
So does the French health system offer universal coverage? Well, not really, in fact, but it's interesting to go back to our history to understand why. So the social security system in France was created after World War II, when we wanted to provide social protection in terms of health and unemployment, disabilities to the French citizens, and the protection system depended on employment. So people who worked had rights in terms of a partial coverage for their health expenses and their families. Now, those who were unemployed had no access to this social protection and had limited access to care. Back in the day, there was another subsidy, so free medical support, which gave them access to free consultations, but it was a little complex. So foreigners who were employed in France also had access to the social protection system, even if they were not recognized as citizens and were not officially residents in France. And as you said, taking care of migrants is taking care of politics, and that is our reality in France. Things have evolved with the change of government, and because in the 1970s France experienced an economic crisis that led to slower growth, migrant workers were less needed and were less wanted, in fact. So there was a turn in policy in France, and we wanted to refrain migration. So some people were inclined to leave, and I'm not saying that's what happened, and people were not pushed out, but some people did leave. And the idea was to reduce the access to social rights for foreigners, especially non-documented workers. And there is the Pasqua law, as we call it in France, illegal workers who could not benefit from our coverage the standard social security that we have, the coverage for the poor, and the other social help and subsidies for French citizens. So, following this, illegal workers were excluded from the health system, which, of course, led to another problem, and they turned to the free medical system that was designed for the homeless and other needy and vulnerable groups. So then there was a movement in order to change things, which led to, in 1998, the law to fight social exclusion. And we developed the PASS, permanent access to care and health services for the homeless, the poor, and people who didn't have access to medical coverage. And then there was a movement for the universalization of the health system. So it's the UHC, Universal Health Coverage, that was voted in 1999. And every French citizen or citizen of France should have access to health care. So this became universal, but the exceptions of the Pasqua law remained, and so the illegal or undocumented workers remained excluded from this service. Then there was a health support managed by the government and the Social Protection Department, which resembles health coverage, and we have this coverage that is specifically for the homeless. So it's a very specific service that we provide in France. So we have issues with migrants and illegal workers, and after many studies and investigations, we realized that there was over 50% of the migrants did not use this universal health coverage. And when we start thinking and looking into why, well, sometimes it's because these migrants didn't need the service or access to health, but mainly because it was very difficult for them to access this health coverage. The access was complexified, became more and more difficult. We're asking people to have an address. And if they didn't have an address, then they couldn't have access to this universal health coverage that was designed for the homeless. So it made no sense. And furthermore, it is only for people who have an income that is below 900 euros per month. So this is complementary to our extra health coverage for the poor, which excludes the homeless. So today, if you are homeless, but you have unemployment and you earn over 900 euros per month, you don't have access to health coverage. And because when you get sick and you have to be hospitalized, expenses are very quickly high, then you have no access to health care. So finally, this state health care, because it is set apart, it crystallizes political tensions because it illustrates the cost of health for illegal workers, and because in France, like the rest of Europe, we are increasingly trying to fight illegal migration. It is one of the rare countries where we can, in fact, count the number of illegal workers in France. So we believe we have about 800,000 illegal workers in France and only 400,000 that are accessing healthcare. So the answer that is provided or suggested by certain politicians is to get rid of this health coverage, state health coverage for these vulnerable groups. But of course, this is not a solution to migration because people don't migrate to have access to health in general. But this state health coverage is now threatened because there is a law that is being developed in order to abolish it, but we are fighting against this. So that's the French example, and I think that it illustrates very well the structure of a health system for providing access to migrants, which doesn't fulfill its mandate because of legal restrictions and because of political positions.
How it is actually in France, but also how it came in different waves, in these different reforms that influenced that access to migration health, in fact. And I just want to pick on one thing, what you have mentioned. You said also that there, if I understood it right, that you mentioned that there were more and more complexity was introduced into the administrative procedures, and that has become then also more complicated. So let me move from and pick up that complexity, because I'd like to move and remain in France to Andrea Tortelli, who is a psychiatrist and at the GHF Paris Psychiatrie Neurosciences. And you are in charge of the consultation for asylum seekers and refugees, but you specifically work on mental health. You also do quantitative and qualitative research on that. So let me just come in, because complexity is part of mental health. So let me ask then for you, if you look at, we have heard about that, healthcare system. We have heard also, how complicated, how it has changed, how it has become restricted. So tell us a little bit more than specifically how that looks for refugees and asylum seekers with mental health conditions, please.
Yes, thank you. I'm going to speak also in French.
So complexity also exists in psychiatric, and actually psychiatrics is an exception, a specialty in France, and one only has access to mental health care even if they are undocumented, even if they don't have a proper coverage. It's a separate unit. One can go to a psychological unit and get support even though they don't have medical coverage. So this is very good for asylum seekers, refugees, at least in theory. In practice, there are hurdles. First, let's remind you that psychiatric healthcare is provided by the public services and is dependent on the regions. And so for every 80,000 citizens, centers are organized. And so depending on where you are domiciled, you have to go to a given center. With regard to migrants, since 2015, we've been facing a different type of people, because we have forced migrants who don't share the same language. And so we have 50,000 asylum seekers in the region of Paris, Île-de-France, for 30,000 housing centers, meaning that most asylum seekers sleep on the streets, not to mention the undocumented migrants and people who have been denied their stay in France. Many sleep in camps or in different places, in train stations, and so on and so forth. Access to psychiatric care becomes very difficult in such circumstances, because once someone is in a given address, well, they depend on a given sector, and it is very difficult to have a follow-up on mental health care. Furthermore, psychiatric health care in France, as in other countries, is mainly aimed at severe and acute disorders, behavioral disorders, anger, and so on and so forth. And most of our patients actually have issues of distress or PTSD. As a consequence, our system is not adapted to these citizens. Furthermore, there is a lack of access to interpreters, even though healthcare says that there is a right to interpreters and there is a special budget for that, but we are not used to working with interpreters at the psychiatric level in France. And furthermore, this triangle psychiatrist, interpreter, and patient tends to be quite complicated in France. And so for many years' time, it has been quite difficult, and many migrants tend to knock on the door of associations, of NGOs. But obviously, those have limited means. They are mainly in big cities, and until lately, this was acceptable because most migrants were in big cities. But with the changes lately, with the policy for housing refugees who are now scattered throughout France, it is extremely difficult because they lack access to these centers, these structures, and the centers who could provide a psychiatric follow-up do it without drugs, but with very limited means for these migrants. As a consequence, today, most of our patients are supported, but not in function of their true needs. We just give some guidelines, and everything depends on convenience, depends on whether there are interpreters or not, depends on the waiting lists, and so on and so forth. And this is not how we should do things. One final word about children. In France, we have a system for adults on the one hand, and then another system for children. And those systems are very different. They are in silos. But when we have a family of migrants, it's the whole family which is suffering, which needs support. And in our service, we actually have a very limited access to psychiatric support to children. And let me give you an example. Today, for pedopsychiatric support, you need to be on a waiting list for 1 year time. Well, thank you. Thank you very much for telling this to us.
A little bit that situation as well, in its complexity, and in fact torn apart in different areas and sections, so to speak, and that makes it even more complex to have really a holistic coverage. Thank you so much. So let's cross the border. Let's come back to Switzerland and to Geneva. So Yves Jackson, thank you very much for coming from the Geneva, from the HUG, the Geneva University Hospitals, and also assistant professor at the Faculty of Medicine. You are working specifically with undocumented migrants, and we have heard about undocumented migrants before. So tell us a bit, what do you see as the challenges? How does that work here in Geneva, in Switzerland? And of course, that's also complex. Switzerland in itself, in its political system, is complex, so let's maybe focus on Geneva. The word is yours.
Thank you very much. Good morning, everybody. It's a pleasure to be here. I'll try to speak in English. If you don't understand, tell me. I'll switch to French. Indeed, for many political reasons, there are different categories of migrants, and some of them are either harder to reach or easier to miss out. And therefore, imagine you are a migrant from a non-European country, crossing boundaries and arriving in Geneva. You don't have visa, you don't have the mandatory health insurance, you don't speak the language, and you have a chronic, poorly controlled medical conditions. And on the other side, imagine you are a healthcare worker working either within a large NGO or the public sector, And you have to address the complex needs of this typical person I just described. So here, at the interface of this encounter, I see 4 main challenges to ensure accessible, equitable, and high-quality medical care delivery. The first one is to create the favorable conditions to deliver quality care. And probably the first step is to create a bond of trust and to overcome fear, distrust, ignorance, and to make sure that people feel safe. And we know that in many settings, healthcare setting may not be safe, especially for undocumented migrants, where personal data can be shared with immigration authorities, etc., etc. Second, how to navigate a complex health system. Nowadays, our healthcare systems are disseminated and fragmented, so it's very complex for a newcomer to understand what is the good door to go through and how to orient oneself in a complex system. And finally, for the healthcare provider, how do you ensure that today, here, I'm able to deliver care that match the needs of the person? So that's the first point. My second point is about going beyond emergency. Usually people engage with the healthcare system through the emergency sectors, which may provide an immediate response, which may save life, but probably do not respond to long-term needs. And the real challenge for undocumented migrants is to access the full range of health services, from health promotion maybe to palliative care. When you have only access to emergency services, there is no way you can meet that need. And this question of the continuity of care and the integration through different stages of your journey across the healthcare sector is a key issue for people who are non-eligible. So it needs extra effort to bridge and connect the different actors. My third point is go beyond health. Usually when you are sick, as a migrant, you are not only physically sick or mentally sick, but you are also socially sick. You need to respond to basic needs, shelter, food, social integration, and so on and so on. So if we only focus our response on health, we may miss out the conditions that make people sick. And as Sir Michael Marmot said, why the hell treating people with the best medical care if it's to send them back to the condition that made him or her sick? So going beyond health seems to be a great challenge. And finally, we need to monitor what we do. And it's very difficult to integrate migrants into research projects, especially over the long term. So prospective or longitudinal studies are really difficult to conduct. Along with the need, and we already addressed that, to develop the training and the capacity of frontline providers to be able to understand the best way to deliver high quality care.
Thank you very much, Yves, for this short and clear. Good to take notes with all the bullet points. But let me pick on one thing, though. You mentioned trust. And I think it is an important element here as well. And it leads me also to the next speaker, to Sally Hargreaves. Sally Hargreaves is from the St. George's University of London. You are a social epidemiologist. You are the section head of global health at the Institute for Infection and Immunity at St. George's. And you're working at that, you're doing research, you're working at that interface between policy and practice and academia. But you also work specifically on vaccine equity. And so trust comes in here when we talk about vaccine coverage. So how does that look like? Let's move into that sort of, how does it look like in terms of, and we hop over here, let me just mention that as well. We hop over to London here, so we go over the ocean, and not the ocean, the water at least. So how does that look like for you? What are the shortfalls in terms of coverage? And we have heard that in COVID-19, we saw that, yeah?
So yes, thank you. Migrants obviously experience specific risk factors for under-immunisation. We see low coverage for routine immunisations in migrant populations on the whole, stemming from weak health systems in their countries of origin, the migration health journey, missing vaccines and doses and boosters along the way. Also, we're quite interested in the missing newer vaccines such as HPV that may not be readily available in their countries of origin. During the COVID pandemic, as you said, we saw clearly in the data slower and lower rates of COVID vaccination in migrant communities when compared to host communities. Due to a range of personal, social and physical barriers to health systems that some of the speakers have already described. So these barriers that we've discussed already, unsurprisingly, also limit vaccine uptake and access in migrant populations. It's important to note as well that there's obviously declining population level coverage for all routine vaccines currently across Europe, which has accelerated post-pandemic. And this places migrants and several other under-immunised groups in Europe at even greater risk of vaccine-preventable diseases. So this is an interesting topic. And I think in terms of sort of challenges around vaccine equity, I think one of the increasing vaccine coverage for routine vaccinations actually cuts across all populations, not just migrant communities. We've seen across the board, many of you will be well aware, a complete decrease in vaccine confidence in Europe and globally, further eroded through COVID, due largely to mistrust in health systems and governments and concerns around vaccine safety, perceptions of low risk of vaccine-preventable disease and low importance of vaccination. So ultimately, we need a broader effort rebuilding trust in systems and providers who deliver vaccinations and do more really across the piece to educate people around the benefits of vaccination. And this, of course, is a key priority of WHO's new 2030 immunisation agenda, looking at vaccination across the life course. So specifically for migrants, from the system's perspective, there are legal, financial, practical challenges to delivering vaccines, restrictive policies around access that we've heard about, a specific issue for undocumented migrants, as Eve's been talking about, but also a much, much wider group of precarious migrants. One European study that we did reported a third of countries charging migrants for vaccination on arrival, routine immunisation, so an obvious barrier. We saw a lot of these sort of hostile access barriers overturned during COVID in several European countries, so migrants could access vaccines. So, there's now a sort of a body of work going on to look at how we can apply these more migrant-inclusive policies to routine immunisation programmes. What's emerged from our work is that older groups, adolescent and adult migrants in Europe, really have no ability to access vaccines because the pathways and the systems just simply aren't there to offer catch-up vaccination on arrival. I think child migrants are a lot better looked after than the older groups. In the UK, it's free for everybody, undocumented migrants, to access basic immunisation, but actually it's not happening in practice at all. The current ECDC guidance, WHO guidance, states that anybody attending primary care, if they have any kind of uncertain status about their vaccine, unclear to what they've had as children, which in my experience is actually most presenting migrants, then they should be offered routine immunisations again for things like MMR, TDIPV and HPV if under the age of 25. So there are pockets of good practice around this, but on the whole it's done pretty badly across Europe. And so we need to innovate here, I think, and start exploring new entry points for catch-up vaccine for migrants arriving to Europe. We could add it to initial health assessments. We could devise new care pathways in primary care, some of the work we're trying to do in the UK, as well as the other speakers have talked about, training our workforce on how to better support these migrant communities. With this in mind, an important group, quite often forgotten, are migrants in closed settings. they spend many months to years in some of these settings. I've recently been down in the camps in Greece, in Lesbos, reception centres, some of these temporary hotels, often with no vaccine offer at all, which I find always quite surprising. We've seen measles outbreaks. We've just had a large diphtheria outbreak in the asylum accommodation on the south coast in the UK, and involving adults, not children, but adults. So this, again, is another entry point here to start thinking about vaccine equity and promoting catch-up vaccination. I think, although there's lots of local pockets of excellence and good practice, and the other speakers may have some good practice from their other countries, I think on the whole, there's really a lack of proactivity by health services in terms of designing and providing tailored vaccine services to migrants. The onus is put on the individual to present for vaccination, and we know the challenges that migrants face with accessing systems. During the pandemic, we saw a whole load of innovation in this area. In London, we had sort of outreach, mobile units going out into the community. We've heard about that from other speakers this morning. Out-of-hours service, anonymous vaccination. We had delivery of vaccines in different contexts, like faith-based venues, community centres, trusted locations. So we need to look at these innovations and see what can be applied now to routine immunisation going forward. And lastly, from the community perspective, obviously, there are a range of personal, societal barriers, beliefs and norms that really do present a lot of challenges to delivering vaccination to these groups that I think needs better consideration. We've talked this morning about mistrust of health systems and authorities. Migrants have a sense of alienation, disempowerment. It's been a strong theme across all our research, and it impacts the desire to get vaccinated. There's also this is obviously compounded by misinformation, disinformation circulating about several vaccines. We also have a range of diverse cultural, religious beliefs and practices that we know impact vaccine acceptance. Some nationalities standing out in our work, the Somali community around the MMR vaccine, Eastern European, Muslim migrants when it comes to HPV. So where things have worked well, we've seen information available in lots of different formats and languages, broadcasted through appropriate channels, being much more mindful of low levels of health literacy and digital literacy, which is another important area. This one-size-fits-all approach that we saw at the start of the pandemic, we know and we saw didn't work. So we realised fairly early on we had to work much more closely with these communities in equal partnership to sort of tailor and design programmes and health information and to disseminate it. And I think, as a final comment, I think co-production, meaningful and sustained community engagement will be at the heart of us finding solutions to lots of these challenges.
Thank you, Sally. Great. So great that you also point out specifically also specific groups like older and adolescent groups. So I think it's great to also mention that specifically. Often we forget. But also that you already bring in the notion of innovation. So there are entry points, there are innovations happening, and there are solutions. So in fact, I'd like to do a second round. I want to build on that and do a second round here and talk about solutions. So we have heard from you all about your system, the problems, the challenges, the barriers. So let's look also constructively on what does that mean now for the future. So where are the solutions? And at this point, I hope to make a very short round, and I invite you already to think about questions, because we will open after that question round. We will open for questions from the floor. Okay? So let me start with Nicola. Because we have heard about social inequalities, we have heard different groups, different access. You also work on social inequalities, in fact, in France. So what are the solutions in an imperfect system, as you have in France?
Thanks. So let's go back to French. Je peux pas...
I obviously won't have the time here to tell you everything I would like to say about the solutions, so I will just pick one. And I will talk a bit about it, bearing in mind that I talk about the French lens. In France, we have the mediation for health. In other contexts, they talked about community healthcare agents or other type of stakeholders. And in France, we have that because there was a need a need to build the bridge between migrants and the healthcare system. There were things that didn't work, there were barriers, hurdles, obstacles, and in order to find solutions, we did realize it was better to have another professional of healthcare, a healthcare mediator, which could be, well, the focal point in between the healthcare system and migrant communities. They can belong of that community or another community and can try, well, to build that bridge so that we have exchanges both ways, and so that this focal point can explain the misunderstandings between the users and the providers of the system. I'm talking about language hurdles, but also cultural hurdles, not to mention, well, the difficulties related to, well, the different levels of the healthcare provider on the one hand and the beneficiary on the other hand. And so this mediator is extremely helpful because he can make sure that beneficiaries do understand what healthcare providers are there to do, and they can help them navigating through the system. This mediator is not an interpreter. They can belong from a given community. We try to reach out to, obviously, and then it's a community healthcare mediator, but it can also be a peer who themselves have a given disease. We namely have this when it comes to mental health care, and we also have some mediators who simply want to be mediators and who are not patient nor coming from a given community. And at my university, we have created a certificate on 1 year training for people coming from all walks of life, and we provide them with some knowledge about the healthcare system, and we explain them how to provide this mediation to several communities and the providers. This is a very old job, but it has evolved in France, and it has been recognized in the French law for health in 2016 and been confirmed in 2017 with a job description. And even though it is recognized now by law, it is difficult to scale up in France because it costs money and it is not covered by the initial budget. So today we are waging a battle with these healthcare mediators, and I'm talking about I'm talking here in the name of the collective for healthcare mediators, who tries to defend this job, because jobs have been created in associations in these healthcare centers I mentioned earlier, the PASS centers. But we would like mediation to scale up, but this would mean we would need more people working in that field, and we would need a bigger envelope from the Ministry of Healthcare. So we are lobbying for that, and we are lobbying for a given training, a given wage, and appropriate funding. So I invite you to bear this experience in mind and to try to emulate it in your local contexts, to maybe try to do something at European level, also to recognize these jobs of mediators. And we might work together in order to promote that. Thank you.
Thank you very much, Nicola. Very interesting. So a new profession indeed, yeah, health mediator, health navigator, who emerged out of need and has actually a formalized training now in France. So that's, a solution. Let me ask Yves, a solution, would that be a solution for undocumented migrants here in Geneva as well? What are solutions for the undocumented migrants here?
I think the key word is integration, and I would mention it at two levels. Integration of health services into the public healthcare sector, for me, is an essential solution, because it ensures the wide range of service available, the continuity, not only continuity of care at personal level, but also continuity of financing, resource, and so on. And I think along with this integration or embedding into the public sector, it goes with partnership, integration into an ecosystem made of NGOs, social partners, other institutions. So actually we have to consolidate an ecosystem in which the migrants, undocumented or not, can find the essential resources that allow him or her to go along his life journey. The second level of integration is individual integration of people with lived experience of migration, both in the delivery of care, but also in the strategic planning. Nowadays, we are drafting policies about people, but without people. And that's a big problem, I think, and I'm responsible for that as well. And this is one of my priorities for the future, to change that reality. Not only for health delivery, strategic planning, but also to create knowledge. And I think we have to change our mindset and to harness resources, not only to deliver services as we have been doing for centuries in a charitable way, but also recognizing that there are very valuable resources to be harnessed, not only because of people's personal history, but also because many of migrants have resources. They have been trained, they have a job, they have qualification, and so on and so on. So I think there is a huge potential of resource that so far is unexploited, and that we can exploit. And I think these two levels of integration, services and people into the general ecosystem, could harness great benefit.
Thank you very much, Yves. So the keyword is integration. And you also mentioned partnerships into an ecosystem, integration into an ecosystem. That brings me to you, Andrea, because you have an ecosystem which is actually torn apart. So what solutions, what suggestions do you have?
Oui, je pense que ça c'est...
Yes, indeed. I think it was good to illustrate, as was done, that the situation is highly complex, and we can't talk about improving mental health if we don't have a holistic approach and we think about social aspects, integration, administrative issues, housing, and of course sleep that needs to be remedied quickly. So we have to have an integrative approach with the patients directly, defining what their priorities are. Some arrive very ill, and some are very anxious just because they've gotten a letter that they can't read. So these are very simple, sometimes very simple issues, but have a huge impact on mental health. What is also needed is to work with common law, with partners. We mustn't just concentrate everything in one service, but we have to have partnerships at institutional level, at legal level, at the administrative level, because that avoids many medical issues and the development of physical illnesses. So in France, we try to go beyond hurdles that exist, that we've talked about, that I've already mentioned. We have a free treatment, free care, and this in partnership with, of course, a psychosocial support. Furthermore, we have to think of migrant care depending on their clinical health. We've talked about mental health, And we are not in a psychiatric realm yet, but if we don't treat these issues, then that will happen. So, first of all, we have to talk about culture, integration, learning the language, isolation, with practices that already have been proven and that are used and known. Psychosocial integration, the help of social experts, interpretation, and all of this will have an impact on their mental health, on their daily life, because if people can't function normally because of anxiety and all sorts of issues, then we can treat them. But before that, we need to solve all these other problems to avoid this type of anxiety. Now, could a general practitioner not be involved and provide this kind of help? We know the efficiency and we know that general practitioners have the right to prescribe anti-anxiety pills or antidepressants, so perhaps that should be the right way to access this kind of treatment. So I think it is important to promote that easy access in France. And in France, we need to pursue the research that is very late compared to other European countries regarding mental health of migrants. We really need to pursue our research in order to better understand the population, the risk factors, and the actions that we can implement in the French contexts.
Third angle out at this point, but I'd like to come back also to what you said earlier, the holistic approach, basically. And I'd like to come back because I want to, as we talk about holistic approach on a policy level, we also mention that all the time, we ask often for that. And with that, I'd like to pass to Sally. Sally, you also work at the policy level. You are technical advice, senior technical advice also to WHO. So you work at the policy level. What are solutions for policymakers?
Ooh, where do I start? So, I mean, I think, sorry to keep harping back to the pandemic, but I think during the pandemic, we saw a whole range of statutory voluntary services rapidly sort of mobilising to engage these hard-to-reach communities. And I think there's still a great deal of learning and innovation from the pandemic that we must apply if we're to ensure access to healthcare, access to vaccine systems, vaccine equity in migrant populations. So this obviously ranges from innovative models of delivery that I previously talked about, removing these restrictive access policies. We did much better around health communication to these groups during the pandemic. And we also really importantly realised the huge benefits of working closely in partnership with migrants themselves and migrant communities, impacted communities. And we learned pretty early on, I think, that you can't respond to health emergencies when there are hundreds of thousands of people outside of mainstream health systems. So I think in specific relation to vaccines, in answer to your question, I think we need to obviously ensure migrants of all ages, and we focus very much on children when it comes to vaccines, but all ages incorporated into policies, strategies, initiatives relating to catch-up vaccination, including newer vaccines such as HPV. Migrants are definitely falling behind on that. Occupational vaccines and vaccines targeted towards high-risk groups such as Hep B. We need to ensure routine vaccines are free of charge. That seems like a fairly straightforward thing to do. We need new access points for vaccine delivery to ensure everyone's included. We need to redesign vaccine systems for migrants that face exclusion, for example, those in camps and reception and detention centres. And all of this, of course, will require additional funding, and Yves talked about harnessing resources, and yes, that's definitely a key point. I think the healthcare workforce needs better training and tools and incentivising to do this work. We need to strengthen these patient-provider interactions. We need to train our health workers on competencies to provide people-centred, culturally sensitive services to migrants. I'd say one of the key challenges we face to moving this forward is the absence of data, specifically around vaccination. I think migrants are definitely not well represented, certainly in European health data sets when it comes to vaccination, and are data systems really fail to reflect the health dynamics of contemporary migration. So as a result, migrants remain invisible, and we really were challenged during COVID with some of this vaccine data and looking at the extent to which migrants are being left behind. It's very, very difficult, I think, to do research in this area without driving changes in how we collect data, and I think policymakers need to ensure financial support for national data collection and establish or upgrade existing information systems. I think lastly to say policymakers really must recognise the importance of co-designing health and vaccine information systems with migrant communities to ensure that they're tailored and targeted to their needs. You know, building trust, building confidence in vaccines and health systems through this continuous inclusive engagement. And we saw a lot of good practice during the pandemic on this. Some models that Nicholas raised using moderators. We work with peer researchers in the UK. There's a lot of models. In the next session, we'll talk a little bit more about participatory health research involving migrants. We need to finance and support these community-led interventions. We need to fund community-based organisations and champions to encourage engagement in sort of vaccination and research. And I think this requires a paradigm shift in how we approach the funding of health research and health service delivery.
Thank you, Sally. Lots of elements here as well, a paradigm shift that we need here, but also that you mentioned co-design. Eve also mentioned, you know, not policies about people, but with people, the inclusion of migrants in the policy-making arena. So, and co-designing. So let me come to Annalie. Annalie, you're also an advocate. You are an advocate for patients' rights. So from your perspective, from the perspective, you know, sometimes we need to push the policymakers so that they do what they're supposed to do. So tell me, from your perspective, what can we do more? What should we do more?
Well, you know, as a refugee health provider, I'm in a growth industry. And in Canada, the number of forcibly displaced migrants being welcomed to Canada has increased exponentially. So in 2022, we received over 375,000 forcibly displaced migrants to Canada. And frankly, our refugee health network of clinics across the country don't have the capacity to meet the need. And so I agree with all of my panelists, like it needs to be that the health system needs to adapt to meet the needs of all residents of Canada, not just the select few. And so I think the health system policymakers need to adapt what's worked well in these refugee health clinics, which have provided equitable access to care, and then adopt those into the mainstream health system. So many of those things have already been talked about, but I mean, basic things like access to interpretation, it needs to be guaranteed for everyone. Two is patient navigation or cultural brokers to help people navigate our very complex health and social systems, and in fact empower migrants to be able to navigate independently, which is what we do at the clinics. And then that co-design that everyone has talked about is so important, and I don't blame Sally for harping on the lessons learned during COVID-19. My team, because I work with refugees and forcibly displaced migrants, and most newcomers to my city, Calgary, resettle in a particular quadrant of the city. And during the rollout of the vaccine, we had the lowest uptake. And it's because there were so many barriers for people in accessing the vaccine. And so public health came to my team and asked us to help improve vaccine uptake within Northeast Calgary. And we did that by doing exactly these novel innovations by co-designing with communities themselves. So So we engaged with communities. Community members actually, provided all the education, the outreach. We went to the communities at mosques, churches, grocery stores, whatever it was, and were able to deliver vaccine in sort of a culturally safe way. And ultimately in the northeast of Calgary, we had 99% uptake of the first dose of vaccine, which to this date, it's the highest uptake in all of Canada, if not North America. So those strategies that we employed during the pandemic with co-designing and engaging with the communities themselves for delivery of a health service, we need to apply that to all health services and to the design of the health system itself. The health system is designed by people like me, like white privileged people. It needs to be co-designed with communities, and all communities, not just migrants, but we're speaking about migrant health today, so they need to be an equal partner, not just token. They need to be an equal partner. And how we've employed that at our clinic is, we're a clinic and also a research program, so we have patient advisors co-designing our programs at the clinic and evaluating our programs. We train refugees, as we call them, community health scholars, but we train them as researchers. And so they're the ones embedded in the community with the community connections, with the trust of the community, and I think our data is much better because of it. And so I think all of these lessons that we've learned just need to be upscaled. In addition, specifically to the Canadian context, where migration is federal responsibility, health, education, housing, it's all provincial responsibility, there does need to be more coordination and planning between the different levels of government. And one of my greatest fears is the risk right now in Canada is that our very fragile sort of the health system, education system, housing sector, they're all under immense strain. And generally in Canada, the public is very supportive of migration, but that has been waning. And some of our politicians are exploiting that in terms of blaming migrants for their current concerns with inflation, cost of housing, inability to access timely primary care, emergency services, et cetera. And so I think this goes back to what others were saying on the previous panel about political determinant of health. And so my concern is that over time, support will wane when the problem is not migration, the problem is policy. And so we need to change the narrative before it becomes toxic and there's a backlash against migration and migrants themselves. So those are a few of my suggestions.
Thank you so much. So we did a broad scope from health navigator of different solutions to patient advisor here, and I think it's a good point also to open up for questions. We do have a bit of time, so what I suggest is actually to have collect some questions. So I will collect a few, 3-4 questions. I will get back to you. You don't have to respond to all. You pick what you like. You can respond. You don't have to respond. Very briefly though, because we have just about 15 minutes left, and I would please ask you also to identify yourself before you speak and be really to the point. Yeah, so otherwise we won't manage the time here. So let's see. I have seen here a hand in front. Yeah, here in the back, there in the middle. Let's start there in the middle. Can we have a mic there, please? Then we have one here. Here, yeah.
Thank you very much for to the speakers for the great presentation. I'm Janet Tenorio. I'm PhD student in the University of Geneva. And actually, I'm working with, my research topic is about undocumented migrants. And I have a question that I think is quite complicated, but all of the solutions that you propose need funding. And how can countries effectively allocate and increase budgetary resources to provide care for migrants, considering competing national priorities in health?
Thank you very much. That was nice and short. We have just one more question here in front, please. Thank you.
Thank you very much for all the presentations. I'm Francesca Edet Okwa, a daughter of Charity of St. Vincent de Paul, representing my religious order at the United Nations here in Geneva. My question is, how sustainable is this aspect of providing health care to migrants? And would it not be better if we could work to find ways of challenging the sending countries to assume their responsibilities so that the individuals who move out of their countries, can just stay at home and be part of the resources of the country? Because as migrants come here, they are providing job opportunities, new researches and things. Who is benefiting and who is losing?
Thank you for the question. We have another question here in front.
Yes, thank you to all our speakers. My name is Agnes Mahot. I come from UCL at the Institute of Global Health. My question was relating to evidence building and gathering relevant data that builds policy and also shapes perceptions. So how do you include people with lived experiences of migration into the policy making and the research? How do you do that effectively?
Okay, great. Thank you. There is one more question here in the back I've seen. Please, yes. And then we get back to you. Okay, I hope you took notes.
Thank you. My name is Benedicta Apoma. My research was on acceptability of sexual reproductive health services by refugee women in Tyrol, Austria. And my question goes to the panelists from France and also to the other panelists. It's interesting that you already have a training program for the migrants to understand what's going on in the healthcare system and how to navigate it. But I didn't hear you or any other panelists emphasize on cultural sensitivity, which I think it's very important. Do the healthcare practitioners get trained on how to be more empathic while dealing with these people? Because from the experience I have with my research, some of these barriers that prevent migrants or refugees from accessing healthcare services in the host country can be overcome if healthcare practitioners can demonstrate a bit of cultural sensitivity. Thank you.
Thank you very much. So with this, I would like to come back to you. So who wants to start? Who wants to give it a start? Sally, you're nearly ready to talk.
I can take the lived experience question.
Yes, please.
So yeah, really interesting question. Quite hard to do, but this is the question about how you include people with lived experience in research and policy making. This is a growing area. There's a paper being presented at the Lancet Migration Series after this, where the researchers from the University of Limerick, who are a WHO collaborating centre now on participatory research involving migrants and refugees. So they look at some of the methods and theories around how to do it. So it's a sort of a growing area in academia for sure. We need to be much more flexible in our funding system so that we can pay people with lived experience. I mean, this is a huge problem we have at universities. You apply for a grant, you win a grant. It's not set up and designed to pay community workers, peer researchers, to sort of be involved with your research. And there's a whole paradigm shift happening with this at the moment. we're sort of trying to sort of unpick all this and how we do it better. We have a group called the Migrant Health Research Community Network, which is 40 people with lived experience of the UK asylum system and migration, and we approach them at all stages of our work. So initial ideas, what research do you want us to do in relation to your health and the health of your communities? We get them involved, we pay them, we reimburse them for their time, and they help us across the entire research journey, from doing qualitative research, we offer training, to actually disseminating and delivering findings of our research within these communities. So that this is a model that we're using, and we've got sort of sustained funding to do that over 2 or 3 years. But so that would be the ultimate aim, I think, if you really want to embed people with lived experience into all the stuff that you're doing, whether service planning. But it's a growing area, and it's quite difficult to do well, I would say.
Thank you, Sally. Thank you for taking the go here. We have 3 more questions. Who wants to kind of pick one or respond to others and add? Nicola, please.
Maybe about national priority. I mean, it's a point. It is the point where migration and healthcare access for migrants is political. So because some people think it could be a priority for national in a context where money is not sufficient, and in the other way we speak today, and there is evidence to build inclusive healthcare system. So no, there is no national priority, and there is advantage for a majority population to guarantee access to healthcare system for migrants, because it's a way to reduce cost as well. It's a way to reduce emergence of infectious disease, and it's a first step for the integration to have a better health. So I think it's not a good point to think about priority of national people.
Thank you so much. Any other thoughts? Yeah, Annalie, please.
Well, I'll just take on the issue around cultural sensitivity. So I prefer to call it cultural safety, cultural humility, and I think it first starts in schools, in the professional schools, whether it's anyone involved in health, the provision of health care. The entire team needs to be safe to interact with people from diverse backgrounds. And I know a lot of medical students that I train seem to think they need to know everything about everyone's culture, but that's meaningless. You need to be curious and you need to ask questions. Just because, I might be Irish Catholic, it doesn't mean you know anything about my thoughts on abortion. So you just have to keep sort of an open mind and be aware that people come from diverse backgrounds. Many of our refugees, of course, have had a history of trauma, so you need to be sensitive to that. But I think cultural safety training needs to be inculcated in the students and then needs to be reiterated, at every opportunity. So not only during training, but after training as well. And certainly in our clinics across Canada, everybody's gone through sort of a formal cultural safety program. But I think that that's insufficient, and I don't think it needs to be scary. I don't think it needs to be scary. I think you have to be curious about people and ask questions and ask them if it's okay and ask them their thoughts on whatever it is you're talking about, and listen. I think if you listen to people and make people feel welcome and safe, that's often all it takes.
Thank you, Annalie. Andrea, you also wanted to take the floor.
Yes, I agree definitely what was said, and I would like to add that it's more a problem, more a question of empathy, because, for example, we have 100 of patients from Afghanistan in our consultation, but each patient is different. So when you are face-to-face to a patient, the more important is to be open and ask questions if you don't understand, and try to listen. Though, so I think I agree, we cannot be experts of geopolitics and what's the interest, but empathy, I think it's the most important.
Thank you, Andrea. Eve, anything from you? Just to add?
Yeah, maybe I try to address the two last questions with
There you
very
are.
humility, cultural humility. So about how to prevent migration, if I understand well, or ensure that home countries provide citizens with the best opportunities to develop oneself at home rather than being forced away. I don't have an answer, obviously. What I can imagine as a topic of discussion is how to make sure that people can do circular migration and not only one-way migration. And there is a challenge now with the nexus of climate change and other factors, conflicts and so on, because people get trapped when they migrate. They cannot go back. And I think that's a big problem because most of the migrants, when they start their journey, they want to go back at some point. So there needs to be development on how best to allow people to get back at some point. And the second about the funding, I think it's a very it's a big hypocrisy, whatever in English. That we ask NGOs to pay for migrants' health. It's a scandal. I mean, and I don't see a good reason why the public sector should not pay for service delivery for migrants. And I think we have to advocate for that because it's the only way that these fundings are sustained over time and comprehensive. And politically speaking, if you look at reality, it's just a drop of water in the ocean. I mean, it's nothing. So I think this is again a political issue. And as professional academics, providers, we have a say that to put things in perspective and to show that migrants won't overflow the healthcare system, they won't skyrocket the cost and whatever.
Yeah, Annalie, please.
I just wanted to add, so I think that's entirely true. So migrants, like in the popular narrative, we have the idea of migrants or forcibly displaced migrants, like we're providing them charitable, charity. But it's not charity, it's investment. And so we know through all the studies done of Canadian migrants, they give more than they ever get. And so I think we need to add this to the sort of mainstream narrative around migrants. It's not charity. We're not giving them health care as charity. We're doing it for everyone in the whole of society. And it's an investment in your human resources because migrants come, as we've talked about, with skills, with resilience, etc. They contribute to society. And all of the studies have demonstrated quite clearly that they give to our society much more than they ever take at the outset.
Yeah, thank you so much. And it's really putting it into perspective. And it was a great panel, so let me thank you all for this. Yeah, putting things into perspective, I hope we did in many ways from a broad scope from different countries. Before we leave, I do want to ask you one little takeaway message for everybody to take home from each of you. 3 words, 1 sentence, not more. So, before we leave the room, that's a challenge, I know, short. Who wants to start? 3 words, 1 sentence. Annalie, please.
My sentence is simply, the systems need to be co-designed with communities that it's seeking to serve.
systems to be co-designed. Thank you, Annalie. Next, Sally.
I would say proactive and meaningful engagement with impacted migrant communities.
Great, thank you so much. Yes, proactivity. Yves.
Positive narrative. Better health services benefit to the whole of the population.
Perfect. Thank you so much. Yves. Nicolas.
Healthcare worker had to advocate for migrant rights.
Thank you so much. And Andrea.
Integrative approach is prevention.
Thank you. Integrative approach is a prevention. Thank you all. Have a good lunch.
Michaela, for keeping the time, and thank you all for your contributions. Remember the questions we asked you at the beginning? So the correct answer was A, and you were 82% to answer correctly, so congratulations. And quick note before you leave, don't miss our exhibitions, including the Global Alliance on Health and Pollution in the atrium and Hall 8. It's right outside the room when you leave, along with displays from Médecins Sans Frontières, the Geneva Center of Humanitarian Studies, and the Concept Foundation. Lunch prepared by the Geneva Health Forum and the SV Group, featuring local seasonal vegetarian food, awaits you in the atrium. We'll meet here again at 2 p.m. Thank you very much for your attention.